Everyone, thank you for joining us tonight. My name is Megan Lear and I work with the marketing team at Hi everyone. My name is Megan Lear and I work with the marketing team at UMHS. Thank you so much for joining us tonight. October is Breast Cancer Awareness Month, as many of you know. And according to the American Cancer Society, breast cancer is the most common form of cancer in women after skin cancer. It accounts for about 30% of all new female cancers that are diagnosed each year. And while research has led to improved survival rates and there are innovative new treatments, breast cancer does remain the second leading cause of cancer death in women. Other common cancers that affect women include uterine cancer, cervical cancer, and ovarian cancer. To raise awareness of these cancers, and also to help identify common warning signs and to share ways that we can support people after a cancer diagnosis, we're really proud to introduce three women tonight, doctors who are here to discuss women's cancers. Two of them are UMHS alumni, and one works on the island of St. Kitts in general surgery at Joseph France General Hospital. She's probably a familiar face too to students who have done their rotations on the island. So please join me in welcoming Dr. Miriam Bernstein, Dr. Laura Tafuri, and Dr. Natalie Osborne. Thank you all for joining us tonight. Dr. Bernstein, I'd like to start with you. Could you please tell us a little bit about your background, when you graduated from UMHS, and also your current practice?
Sure. Hello, everybody. So my name is Dr. Miriam Bernstein. I'm a UMHS graduate from the class of 2016. I'm currently a OBGYN physician in upstate New York at a little hospital called Oneida Healthcare. And I'm born and raised in this area, so it's very cool to be coming back and giving back to my community. So I'm excited to be here tonight, and thank you guys for joining us.
Thank you, Dr. Bernstein. Dr. Tafuri, could you tell us, you're a more recent graduate of UMHS. Could you tell us a little bit about when you graduated and what you're doing now?
Yes. Hi, everyone. My name is Dr. Laura Tafuri. I graduated in 2018, and I'm a chief resident this year in OBGYN at Bridgeport Hospital in Yale New Haven Health in Connecticut. And I also, like Miriam, I'm from Connecticut, so I landed back here. And I'm in the process of looking for jobs for next year as an attending.
Great. Thank you so much. Thanks for joining us. And last but not least, Dr. Natalie Osborne. Thank you for joining us. Can you tell us a little bit about your background and your current practice?
Okay, my name is Dr. Natalie Osborne. I'm from the island of St. Kitts and Nevis, a very small island in the Caribbean with a population of approximately 50,000 persons. I work quite closely with the UMHS students when they come to the hospital, our general hospital, doing their rotation at the end of each semester. I also work in private practice, and I'm what we consider a true general surgeon, because on a small island, the general surgeon has quite a lot to do, working from the head to the feet, doing various different tasks, because in a small island, we're limited with different specialized areas. So the general surgeon would have to work on the neck. We do a lot of trauma. We do a lot of abdominal surgery. We work on the extremities as well. So we cover quite a bit on the island. So it's lovely to be here with you guys this evening.
Thank you. Thank you so much for joining us. Before we get started on our discussion, talking about important cancer screenings for women, I did just want to invite the audience, as we're having this conversation tonight, to submit any questions that you might have for anybody on this panel. If you enter your questions into the chat, we'll try to monitor those questions and ask the doctors on this panel your questions throughout. So please feel free to engage with us, ask us questions. We're here to share experiences and insights. So we invite you to ask your questions as we go through our discussion tonight. So focusing on just women's health in general, Dr. Bernstein, I wonder if I could start with you just to talk about the most common cancers that affect women and the ones that you see in your practice.
Sure. So the most common cancers in women, apart from skin cancer, are breast cancer, lung cancer, and colon cancer. Breast cancer, meaning the topic of our discussion tonight, affects about 1 in 8 US women. So it is extremely prevalent in the US population. Breast cancer, colon cancer both have screening implementations from various recommended, various colleges of thoughts. There's different guidelines depending on who you follow. The USPS task force has one, as well as ACOG and some of the other colleges, I guess, that tell us what to do. So there's several different guidelines, like I said, in place for those cancers. And then there are also the ovarian cancers, the cervical cancers, vulvar and vaginal cancers, as well as uterine cancer. Cervical cancer, as everyone knows about pap smears, that is very easily screened, as well as the vaginal cancers go along usually with that category. The tricky thing for us as OBGYNs is that endometrial and ovarian cancers don't have routine screening guidelines. So those are ones where we have to kind of pick up on them clinically. And unfortunately, sometimes it's not in an early stage. So definitely something we need to be aware of across all walks of medical specialties.
Perfect. Thank you. My next question is for Dr. Osborne. Dr. Osborne, you work on the island of St. Kitts and Nevis, and there's a large population of Black women on the island. Just wondering if you could talk to us a little bit about breast cancer and if it affects Black patients disproportionately, if you have any insights regarding how it might affect that population.
Okay, thank you for that question. So on the island of St. Kitts and Nevis, because it's a small federation, most of our, over 98% of our population are Black descendants. We do have a large population of a large number of cases with breast cancer, but it follows the worldwide trend though, where breast cancer is most common in the female, the white female, non-Hispanic white female. However, when breast cancer does affect the Black race, we tend to see it at a younger age. And usually when it occurs at a younger age and the disease is more aggressive. Hence leading to oftentimes, because we start screening at a later age, sometimes a person can be missed, leading to a case being diagnosed in a later stage, resulting also in a later diagnosis with a poorer outcome. Also, when a Black persons are diagnosed with breast cancer, it's usually a more aggressive cancer. For example, the triple negative breast cancer, triple negative as in ER, estrogen receptors, the progesterone receptors, and the HER2 receptor negative. So those tumors are usually much more aggressive and when seen in Blacks. And what I've seen sometimes, especially in the developed countries, because of the socioeconomic disparity among the Black population, these patients are diagnosed later, and they have poorer outcomes because of the limited access to medical care. And that is some of the main reasons. So in summary, usually Blacks, when we do develop breast cancer, it's usually in a younger population. The disease usually a much more aggressive disease, and sometimes because of lack of financial support, they have less access to first class or the best medical treatment, hence leading to a poorer outcome.
So as a follow-up question to that, because I think you brought up a lot of really good information, what are some ways that healthcare practitioners can be proactive in screening patients who, might not yet be 40 years old and recommended for a mammogram, for example, or who might not go to their OB-GYN for regular screenings? What are some ways that you would suggest that practitioners can encourage their patients to be more proactive about their health and getting an earlier diagnosis?
Excellent question, because we struggle with that here on the island quite often, and I could imagine some of my colleagues here also would share the experience. Oftentimes here, women are so involved in doing their day-to-day life, the struggles that they have, they're dealing with their families, the limited resources, so they put their personal health under the sideline and oftentimes coming later. We often see our patients with breast lumps at a very later stage where the tumor is large, sometimes eroding the skin. We often find women who come in with pretty advanced cervical cancer, ovarian cancer. What we're trying to do here, though, is do lots of health promotions where we're trying to educate our population. We reach out to them. I have started a Facebook group sometime. I would post different information on different healthcare topics, trying to promote and encourage our female patient. In this month of October, where it is Breast Cancer Awareness Month, the oncologist and myself, who we work very closely with, the medical oncologist, we started doing breast cancer screening free of cost for any women who want to come and get their breasts examined by their clinician. So we do that, and we've been able to speak to some of our local females, encouraging them, educating them on the importance of doing their pap smear, the importance of getting their regular screening mammography. So I think the bottom line is education. No matter where you are in the world, we need to educate our female population, reminding them the importance of screening so that early detection of these deadly cancers like breast cancer, cervical cancer, we can make early diagnosis and implement treatment that can save lives and increase their survival.
Perfect. That's very helpful. Thank you. And just to kind of take a slightly different approach to that same question, I was going to ask Dr. Tafuri, if you could tell us a little bit. So we've had Dr. Osborne talk a little bit about the education campaign and how practitioners can help be more proactive. But as you're working with your patients, what are some things that women can do, that patients can do to be more proactive? Maybe talk about certain self-exams or screenings that as women we should take charge of and make sure that we're staying ahead of our health. What do you recommend?
Yeah. So I think it's really important, starting from the provider aspect, is that if you're comfortable talking to the patient, you'll make them feel comfortable. And there's so much hype about going to the OBGYN for the first time, and I don't know why, but I also was so terrified. And I don't know why, because it's really not a big deal. So I think it's important when you have women, especially at a young age, coming in for something simple, whether it's birth control counseling or STD screening, and they're not yet at the age to be starting pap smears, it's super important to kind of capture them at that moment and say, hey, in 2 years or 3 years, we're going to start doing a pap smear, and this is what it's like. And it's really important because of this. And I think it's really important also at a young age in that same population to start talking about self-exams. And every time I see a patient, I ask them, do you do a self-exam on your breast? And most of the time they say no. And I say, do it in the shower. And this is what you need to do. This is the position. This is what you feel for. And don't do it during the time you're about to get your period, because your breasts are always kind of, I say, lumpy bumpy, and everyone always smiles because they know what that means. And so I think it's important, as soon as you make them feel comfortable and educate them about, you need to know your body, and that's important, and they can come speak to you freely and feel comfortable coming in for any concerns. I think that that's really important. And that's really the first step. At a young age, you want people to feel comfortable coming to you with concerns.
Absolutely. That's a great point. It definitely underscores what Dr. Osborne was saying too about education just being so important, to just raising awareness and letting people know how they can take charge of their health. Just related to that point too, there's been a lot of talk about the HPV vaccine as a way to try to prevent the virus that causes cervical cancer. And there are a lot of myths and misconceptions about that vaccine. There's a lot of wariness about the vaccine. Dr. Bernstein, I was wondering if you could tell us a little bit more about it and just sort of educate our audience, kind of dispel some of the myths, separate fact from fiction, who should get it, all of that good info.
Awesome. Sure. So it's a great question. If I gave you my honest opinion, I think everybody should get the HPV vaccine, but obviously insurance companies don't love that answer. But it is FDA approved for both male and female patients from ages 9 to 45 in the United States, which is awesome and such a broad range. The preference is that you get it as young as possible. And the reason for that is that HPV is the most common sexually transmitted infection. Approximately 85% of sexually active people will have it at some point in their lifetime. HPV obviously has two kind of different forms that we think of as far as OBGYNs. You think of the strains that cause genital warts, which are usually uncomfortable and embarrassing and can be painful for our patients. And then you worry obviously about the cancer aspect. So some strains of HPV are involved in cervical cancer, vaginal cancer, as well as vulvar cancer. So the HPV vaccine, Gardasil, has a non-valent, which means it vaccinates against 9 different strains of HPV. And that's really, really important for patients to get that before they even get exposed to the HPV. So obviously everyone has different, and we'll touch on that. Everyone has different ideas about the initial encounters in your teen years or your 20s or your 30s or 40s or whenever. And so we prefer to get the HPV vaccine on board on the patient as young as possible. And that way we can help prevent that initial infection. The HPV vaccine, I have to say, is very much credited with how low our cervical cancer rates are in the United States. I can only speak to my training. I can't speak to Dr. Tafuri's, but my training, I saw very little cervical cancer. I've seen a lot of pre-cancer, a lot of dysplasia of the cervix. However, to see occult cervical cancer has probably only been maybe a dozen cases in my career, whereas I've seen hundreds of cases of ovarian and endometrial cancer. So comparatively, we are very, very lucky in the United States to have the vaccine available and have the technology. We just need to convince everybody to get it. And that's an education thing. And that goes to the parents, that goes to the pediatricians. I work with some pediatricians who have certain ideas about the HPV vaccine, and you just try to say, hey, I think it would be really cool if we talk to our patients about this. You're not condoning sexual activity. You're saying when that happens or when that exposure happens. It doesn't always have to be sexual, which is what people need to realize as well, that you can help prevent a cancer, which to me is just, it's amazing that we have that technology. Like, why would you want that issue for your child in the future, whether it's 10 years from now, 20, 30 years from now? And I mean, the HPV vaccine is not only great for females as far as cervical, vulvar, and vaginal cancer, but it's also great at preventing some forms of rectal cancer, as well as, unfortunately, thinking of myself in this scenario, HPV is responsible for head and neck cancers. And unfortunately, the people who are at higher risk for head and neck cancers associated with HPV are your healthcare providers who do surgeries on patients who have HPV. So I myself, as an OBGYN, am at extremely high risk for developing head and neck cancer secondary to HPV, because when I'm doing cervical surgeries or vaginal surgeries with somebody who is infected, it aerosolizes and it can actually end up in my air passages. So I actually I was wearing an N95 before it was cool to wear an N95 in the OR to help prevent that. So that's actually a huge thing for us to know as medical professionals. So no, I'm a huge proponent of the vaccine. Long story short, I think everybody should get it. I think pediatricians should be more proactive about it. And we as OBGYNs should be more proactive about it as well and offer it very routinely in our offices.
Thank you. I think you addressed a lot of the concerns that people have about the vaccine. And I think that responding with the evidence that shows how it, reduces the risk of all those different types of cancers is pretty powerful and persuasive. Dr. Osborne, this question is directed towards you, kind of related to that. And that is, how can doctors alleviate women's fears of getting some critical screening? Dr. Tafuri kind of addressed it a little bit, that people have expressed to her that they're nervous about getting their pap smears. Some women are very nervous about getting mammograms. But what can doctors do to make those routine screenings more comfortable for patients?
Okay, so just to jump on first and make just a slight comment as to what Dr. Bernstein spoke about, because she spoke clearly about the vaccines. I know that they use the Gardasil and the Cervarix quite a bit in the United States. And to add that, it is very important to start the treatment very early, even before the patient is exposed to the HPV virus. We know that the HPV virus causes cervical cancer. Usually persons who have not been exposed to the HPV virus usually do not develop cervical cancer. The most common of these strains are the 16 and 18 that tends to cause the cervical cancer. And also in males, so why is it important? Because it can cause penile cancers as well as anal cancers in persons who engage in anal sex. So with our patients as you asked the question concerning making our patients more comfortable, usually it comes back to education. I sit down often with my patient, explain the importance of having it, even though at times you may somewhat feel uncomfortable. Because women have told me many times, oh, they're afraid of having their mammograms. And I will tell you a story that my stepmother had her first mammogram when she was 62, because her fear was that it would be painful. And I sat her down and spoke to her and tell her that no, and even if there is some discomfort, the discomfort is short-lived. And the benefit of having an early diagnosis far outweighs any minimum discomfort she may have just for 2 minutes, 3 minutes when the procedure is being done. We also want to educate our technicians, everybody who's working in that atmosphere in doing these procedures, to be as professional as they can, to make sure that the patients feel extremely comfortable, respecting their privacy and stuff. So I do a lot of sit-down conversations with my patient, explaining the benefits versus the risk, and late the diagnosis can lead to a poor outcome. And once patient understands that early diagnosis can lead to less invasive surgical procedures and a higher survival rates in 5 years, in 10 years, in 15 years, patients are willing to undergo the discomfort that may be doing a mammogram or doing your pap smear that is just short-lived. So everything comes down to having good education to your patients and taking time out to be the doctor that explains clearly and informs the patient adequately.
Perfect. Education is definitely a recurring theme tonight throughout this discussion. It's clearly critical. And you touched on something else that I was wondering if you could just elaborate on a little bit more. And that is just kind of making it personal, sharing like your personal story. I was wondering if you could talk about the power of that in persuading your patients to seek care.
Okay, the power of persuading your patients, it comes down to trust. One of the strongest example of that was a family member of mine who was diagnosed with breast cancer very young. And going back to the point of Blacks being, when they're diagnosed with breast cancer, they can be diagnosed at a younger age. The disease is much more aggressive. I have a cousin who was diagnosed with breast cancer at the age of 30. And she has triple negative breast cancer. She underwent a mastectomy. She's been doing chemotherapy, radiation therapy. And before she made up her mind as to what form of surgical treatment that she would choose, ultimately she decided to have the mastectomy because she was resistant at first. I had to sit down with her, encourage her, let her know that even though it is a hard choice to make. It is important that she's around for her family, around for her kids, because she has 3 boys. And she has a strong family history of having breast cancer. And just this month, her mother at 55 was diagnosed with breast cancer. So she has a really strong family history. So it's important to be that support system, because I've been there for her and her mother after she was recently diagnosed with breast cancer. And I've been encouraging her and giving her the necessary support that she needs. So one of the things that I think that is important, just being there for each of these persons, because everybody has to first accept the disease and get to a place of accepting the necessary treatment and going forward. But all you have to do is just give them the time, be patient. Usually the patient will make the right decision, you know?
Definitely. Thank you. And just to kind of add on to your point, Dr. Bernstein, I know when we had our prep call for the discussion tonight, you had some other ways that you could get your patients to remember to be proactive. Like, what do you need to do on your 21st birthday besides, you know, having your first legal drink in the bar? I was just wondering if you could share some of the other ways that you work with your patients to get them to be proactive about their healthcare.
Absolutely. So definitely education, is both of my colleagues have spoke about, is essential. I think as being a physician, and I can't speak for them both, but I think they would probably agree, is that you're automatically thrust into this position where you are seen as kind of a go-to person and a leader in your community. And even if you never thought of that as coming along with being a physician and coming with the title of it, you're automatically seen that way. So I think using that, I don't want to say power, but like using that perspective to be able to help more people. I mean, I literally get pulled into rooms by my nurses, and they're like, "Hey, I have a lump. Will you feel it?" And I'm like, "Hey, can we have an appointment? Like, can we do this in a more formal setting with a chaperone and everything else?" But like, that approachability is so amazing. And as a physician, I don't think that was something that I realized was going to come along with the job, that people just come up to you and they ask your opinion on these things. So I think not taking advantage, but using that relationship that you build with people around you, your community, your friends, your family, your coworkers, and just being like, "Hey, let's get you in, let's get this done." And I think that approachability, in all honesty, gets a lot of traction as far as getting people to come in for these screening exams. You don't want to be having that exam done with somebody who you don't trust and somebody who you don't feel comfortable with. It is scary, your first pap smear. I completely agree with Laura. My first OBGYN experience, I had no idea what was going on. I remember sweating so much I stuck to the paper on the table. It's just something, it's not something fun. Our mothers never told us, "Oh, this is the best part about being a woman." No, it's not. But it's also amazing that we can prevent things from becoming life-threatening conditions just by going in and having somebody look or do a pap smear or do a breast exam. So as far as empowering our community and screening, that to me is huge. And just sharing stories of, wow, I found cervical cancer on this patient who I just thought was having, a polyp on her cervix and having some bleeding, associated with intercourse. And then boom, she has cervical cancer. And it's like, you just saved that woman's life. And as a physician, I mean, you remember those moments when you're able to catch something before it becomes something horrible. So I think just sharing those stories with the people around you, once you go out into clinical practice, and they really do absorb it and feel more comfortable about it. And then I have my nurses who I work with, they're bringing their daughters in for exams. And like I said, like you mentioned, "Hey, you're 18 years old, I'll refill your birth control. You're going to come see me in 3 years. When you have your first drink, remember you need your first pap smear." And tell your friends to come in for their pap smears too. I mean, I literally see like an entire family of girls, like one after the other, for their paps every year, all on the same day. And mom just like, loads up the car and brings them all in. And that's what you want. Like that's what's going to really affect your population health and really improve your outcomes as far as these diseases go.
I love that about the mom bringing in all of her daughters. And that brings me to another point, which is family history and the importance of family history in diagnosing cancers and identifying people that are more high risk. And so, Dr. Tafuri, I know that for many of us, breast cancer hits very close to home. You've had breast cancer touch your family. I was wondering if you would kind of talk to us a little bit about that and also talk about why family history is important. And some things that people should be aware of, symptoms, and also some things that healthcare providers shouldn't ignore when they're kind of taking an inventory of their patients and doing assessments.
Yeah, absolutely. I just have to say that I love that Dr. Bernstein said that she was sweating so much she stuck to the paper, because the same thing happened to me. And I was like mortified when I went home. And my mom was laughing at me, calling me the Charmin bear, because I had like the paper stuck to me. And now in retrospect, I'm like, that was so not a big deal. I don't know why I was freaking out, but I love that you also had that experience. It makes me feel better. As far as my family history, I have had 2 aunts and most recently my mother diagnosed with breast cancer. And my mother and one of my aunts had this picked up on routine screening. And I think that that's something I tell my patients now. That's really important, that this is the point of screening, whether it's pap smears or mammograms. This is why it's there. You need to go annually, because something can be there or something cannot be there. And then 6 months later, there's something there that needs to be followed up on. So I think that that's really important. And I like to use that story to really drive my patients to come in for their screening and not be scared, because that's the best way to prevent cancer, is to come for your screening. On the other side, my aunt, who unfortunately passed away from breast cancer, felt something in her breast, went to her doctor, and he had said, "Oh, no, it's not really anything. Like, we'll just keep an eye on it." And then about a year later, she went back and it was larger. And she said, "I'm really concerned about this." And unfortunately, at that point, she was diagnosed with cancer and it was metastatic. So it's really unfortunate. And I think that when I have people come in, no matter what the age, they're concerned about something. So you need to take it seriously. And even if someone is young, we're seeing breast cancer earlier and earlier. And it's really important. Every single time I do an exam or an annual, I'm doing the breast exam, I'm teaching them how to do the breast exam. I'm asking them about their family history. Do you have anyone who has breast or any GYN pelvic cancers? I always ask, because family history is a huge component of these cancers, especially breast and, the other GYN cancers, colon as well. So that's not something to overlook either. So I think that that's, really important to stress to the patients. To know their family history, because even when my mom was diagnosed, there was things I didn't know about her. And I'm like, why didn't I know this? And so many times patients will say, "Well, I don't really know about my mom or someone else in my family," because a lot of people don't talk about things, their health screenings. Sometimes that's culturally not really a thing they talk about. Even if it comes to like the age of menopause, some people go into menopause earlier, and we always ask, "When did your mom go into menopause?" And they're like, "I don't really know. We never talked about it." So I think telling patients to talk to their family, get their family history, be aware, come in for their concerns is really important. And being comfortable coming in to talk about whatever they feel and addressing it seriously. If it's just an ultrasound, if they're not old enough to get a mammogram, just taking everything seriously. And like the other women spoke about, trust is huge. So if a patient feels like you blew off their concern, they're going to lose trust in the healthcare system, and they may not follow up on something later on that needed to be followed up on.
Absolutely. And I'm sorry about your aunt. We have a question from the audience, and that is, at what age should one do their first mammogram? So Dr. Tafuri, do you want to answer that question?
Yes. So women should start now. They've kind of changed the age. So we tell women to start around 40. If there is any sort of genetic history, and this is involving first degree relatives, so sister, mother, first degree cousin, then that have been diagnosed with breast cancer, especially early on in life, we want to make sure they're coming in earlier. Usually around 35. And it's the same thing with colon cancer too. So that's why when we're seeing these patients, I always ask, not just breast, ovarian, uterine, cervical. I always say, what about colon cancer? Because that all falls in the same thing. And it's important to discuss with your patient, because we don't, or at least correct me if I'm wrong, I don't order the colonoscopies like usually the primary care doctors do, but it's important that they know because you're there with them at that visit. So it's your job to remind them to, oh, okay, you also need to be doing this, even though I'm not dealing with your colon directly.
So Dr. Bernstein, I'm going to direct this question to you because Dr. Tafuri brought up an interesting point about her aunt's doctor, not following up on the lump in her breast. And, as an OB-GYN, what are some symptoms that patients and doctors should never ignore, that should always require follow-up? And what are some common warning signs that people should be looking out for, that patients should be aware of, whether it's breast cancer, uterine, ovarian cancer? What are some red flags?
So definitely on the breast cancer topic, any kind of changes in your breasts, whether you notice it, whether somebody else notices it, whether your breasts start to feel different to you. I tell all my patients breast awareness. If you don't want to do exams every month, if that makes you feel uncomfortable, know what your breasts feel like, know what's normal, how they normally look. Any changes in that, I tell them, keep an eye on it for a week or two if things don't get better, because the breasts, as Laura mentioned earlier, can change during the menstrual cycle. If things don't get better in 2 weeks, call me. And I tell my patients, I'm like, a breast ultrasound does not give you any radiation. It doesn't cost a lot of money. As long as you live in an area where, it's not a 3-hour drive to go get an ultrasound done, then to me, as a practitioner, I will always order a breast ultrasound. And that has a pretty good sensitivity as far as picking up on something, if there is something to be concerned about. Other things that you can notice is any kind of skin changes in the breasts. I think I touched upon that. Any new rashes that don't seem to be going away. You notice it on one breast and not the other. Especially issues with the nipples. If your nipple used to be everted, now it's inverted, or if you notice nipple discharge or bleeding. Same thing with the armpits. If you start to notice that your armpits feel like bulky or your shirts are fitting differently, that can also be a sign of breast cancer. As far as the other GYN cancers go, down closer to the neck of the woods, I feel more comfortable discussing any kind of bleeding that just doesn't seem to be associated with a menstrual cycle, or if somebody is postmenopausal, any kind of bleeding in that area is not normal, whether it's rectal, whether it's vaginal, even whether it's coming from the urine. Any of those things need to be discussed with a physician or your practitioner. Ovarian cancer is the scariest one for me as an OBGYN. And I think Dr. Osborne would probably agree that that is the scariest thing, to go into someone's belly knowing that you're going to deal with, because ovarian cancer isn't nice. We usually find it stage 3 to stage 4. And that has very nondescript symptoms. You can have, you're not eating as much, but your belly feels bigger. Your pants don't fit. You're losing weight, but your belly's, like I said, getting bigger. That to me is, I can remember every single patient who's described those symptoms to me, and that feeling in the pit of my stomach that like, this isn't going to be good. The endometrial cancer is essentially any kind of changes in bleeding, menstrual bleeding, especially as women age and get closer to menopause, all of a sudden, oh, I thought my periods were going away and now they're super heavy every month. That's a red flag. And then the vulvar cancers, anything that's causing you discomfort down there or feels different down there, have somebody take a look. That's a registered, professional. And I just, self-awareness, that's my huge thing that I try to preach to all my patients. If something doesn't feel right, just go in and be seen. And if you feel like your doctor doesn't listen to you, I tell my patients, and maybe this is a little crude, but medicine is a business. I hate to say it, but it is. And if your doctor isn't holding up their end of the business deal, then you need to find a new one. And, we're lucky enough to be in a country that has sufficient medical professionals, maybe not as many as we would like, but there's always going to be somebody who's willing to listen to you and willing to sit and talk with you. And that family history that we were talking about earlier is so important. And genetic testing is so freely available compared to even when I started training. And now I have patients that come in and they probably 25% of my annual visits qualify for some kind of genetic screening just based on their family history. And we're getting them all registered and getting their blood drawn. And it's awesome because it's all going into a big registry, and then they're following patients and finding out who develops, cancers of the breast, colon, ovarian cancers, endometrial cancers. And we're learning more and more every year about, who has genetic susceptibilities to these diseases. So I'm really, really hopeful, especially with the advances in technology.
And then another quick question from the audience, Dr. Bernstein, how often should a woman get a pap smear?
This is a tricky one. So there's several different guidelines. Right now, the guidelines are in the 20s. A woman is supposed to be getting a pap smear every 3 years, and that's from ages 21 to 29. If those pap smears are normal, when she turns 30, there's a recommendation to do a pap smear every 5 years. And when that pap smear is done, it's done with HPV co-testing. So the HPV co-testing and the pap together are supposed to give you sufficient peace of mind as a practitioner that the patient is unlikely to develop full-blown cervical cancer in the next 5 years before you screen them again. If the HPV is positive or the pap smear is abnormal, then it changes the guidelines. So it is very controversial. Even some of my partners at times are a little bit hesitant to let somebody go a full 5 years. I tell patients still come in for your annual exams. We still do a speculum exam. We still look. If the cervix looks abnormal, you can bet I'm going to pap it, and just make sure that there isn't anything developing that's concerning. But the way that we are taught is that it takes 10 years to go from an abnormal pap smear to cervical cancer, so that you should be able to sufficiently check it in someone who is routinely screened and has good follow-up.
Perfect. Thank you for answering that question from the audience. Dr. Osborne, the next question is for you. In addition to treating patients at the hospital, you made reference to the fact earlier in this conversation that you've helped family members through cancer diagnosis. And I just was wondering, as both a practitioner and, a aunt, cousin, friend, what is the best way to support someone after they've gotten their cancer diagnosis?
Okay, very good question. The best way to support the person, you've got to be all in, because the support is going to come psychological. It can come financial. Financial could be taking them to a long distance for their mammogram, taking them to the hospital when they need you to be there, sit with them, follow up on their tests, do whatever things like that. You can also be there. You can babysit for them. Like my cousin, sometimes I would have taken her kids for a drive for pizza so that she can have a moment. So the support comes socially, psychologically, financially, because we live in a country, in an island, that the socioeconomic restrictions are real. So you then have to support these individuals in so many ways, and oftentimes it comes in financially. You have to assist them when getting a mammogram. I've often had to do that, assist them in getting an ultrasound, because she needs a follow-up ultrasound. She had to do screenings where she needed to get a chest x-ray, because this particular family member of mine, she now has stage 4 breast cancer. Okay, she has metastasis to the lungs. So oftentimes I'm there and I come to for her. So that is where the support comes in. It comes in many different forms. Just sitting with the person, encouraging them, let them know that because of the advances in medicine, persons with stage 4 breast cancer, stage 4 diseases are living longer and longer. The 5-year survival rate has been extended with all the different advance in hormonal therapy, and so these persons are doing much better. So you have to be there for that person in any way that they need you. Sometimes it's just to leave them alone, let them have a minute as well too, so they can reflect and take some personal time.
Perfect. Thank you. And Dr. Tafuri, I see you kind of nodding along. Just wondered if you had anything that you wanted to add to that point.
Yeah, no, I agreed with everything she said and everything Dr. Bernstein said. I was just thinking about something that one of our GYN oncology attendings said to me. We had a really young patient have end-stage cervical cancer. She was 36, had a large cervical mass and ignored it because she didn't want to come to the doctor. And by the time we saw her, it had spread to what we call the perimetrium, so like the surrounding tissue. So her whole pelvis was kind of firm when you felt it. And that's when you know it's really not good. And it was actually blocking her ureters. So it was, she couldn't drain urine properly. And it was really sad because she passed just a few months after that. And my attending said to me, no one should be dying of cervical cancer nowadays. There's no excuse. That's why it's so important to have people feel comfortable coming in for your annuals. And like Dr. Bernstein said, even though for most people who are having normal PAPs, there is years between these exams, I always say, okay, your PAP's normal. You still need to come back next year because we still need to do a breast exam. And I always do an abdominal exam. And we still need to look in with a speculum because we need to look at your cervix, your vagina, everything every year, because a lot can happen in 5 years. You never know. People have new partners. There's a lot that can happen. So that always just sticks with me. She's like, no one should be dying of cervical cancer now. And like Dr. Bernstein said, ovarian cancer is definitely harder because unless someone has the BRCA mutations or something else genetic, it's really hard because when people are presenting with concerns, it's usually advanced stage because there's just no good screening. So that's obviously difficult, but I just agree with both of them. And I just always think about that. And I stress that to our patients too, that we have all these tools, we can help you. You just have to come in.
Right. Good point. And Dr. Bernstein, I saw you kind of nodding along too. Just wondered if you had anything else that you wanted to add or talk about what I know we've kind of harped on this a lot, but it's important as part of our education here tonight, just what every woman should do to make sure that they are taking control of their health.
Absolutely. So I just gave this speech to one of my postpartum moms earlier when I was rounding, is that you can't take care of other people if you're not taking care of yourself. So getting in for screenings, getting in for the other things. I mean, it's just as important as going to the spa for a day or going to get a massage or taking yourself to TJ Maxx if you're me, or Target. It's important that you do these things for yourself, and you're never too busy to not get a pap smear. You're never too busy to not go to your primary care doctor and talk about screening, talk about changes in family history. I mean, you hear lots of stories about people, oh, somebody was diagnosed with cancer in my family, and I finally went to the doctor for the first time in 20 years, and they found a whole menagerie of problems. But we are so lucky to be living in a society where we have these resources available to us, and I think fear is a huge part of it. You're afraid. What if they find something? What if they do? But what if you don't get to see your kids grow up? What if you don't get to see, you don't get to go to your child's wedding? What if you don't get to help raise your grandkids? Those are important things that I try to instill in people. And like I said, just being an approachable practitioner, you're going to start having people come up to you in the store. I'm sure Dr. Osborne's very well known at St. Kitts. I'm sure people just run up to her and, start talking about their health problems. And you're like, whoa, I'm just trying to get my groceries here. Because it happens. And it's amazing that people trust you that much, but you need to be able to encourage that proactivity in the community. And then the only other thing I really wanted to talk about that I don't think was stressed enough in my medical training, and I did actually have one really good GYN oncologist who stressed this, is survivorship. So as Dr. Osborne mentioned, we have so many amazing technologies, medications that are allowing patients who have the diagnosis of cancer to live longer and to live with their diseases at points when, it would have at other times been, get things ready. You only have a couple weeks to live, and people are living months, even years with terminal diagnoses. And I think being a practitioner, you're going to start to see patients who have these diagnoses and who feel guilty that they're not enjoying the normal everyday things. Being an OBGYN, my patients talk to me obviously about their sex lives. And I think it's really important that we let them know that that's okay to talk to me about it. And it's okay to complain about it and say, listen, ever since I've had my mastectomy, I don't feel like a woman. What can I do? Or ever since I've been on this treatment, or I had my ovaries removed for my ovarian cancer, I have issues with dryness. I have issues with pain with intercourse. And just being able to have those conversations with your patients and to let them know they don't need to feel guilty about that. One of the local university systems near me here does have an amazing survivorship program, and they have psychological care, they have sexual therapists, they have all sorts of resources. And just knowing that that might be what your patient needs, and that they're not alone in those concerns, and you didn't survive this horrible, horrible disease, or you're not living with this horrible disease to not enjoy your life and not to enjoy that aspect of your life. So I think that's really important for us to know that those resources are out there, and that we should make our patients feel comfortable to talk about those things with us.
Those are excellent points. Thank you. Just sort of switching gears a little bit, shifting away from kind of the screenings and talking about the different women's cancers. I just wanted to focus a little bit, since we have a lot of people tuning in tonight who are current and prospective medical students, want to shift our focus a little bit more into just the practice of medicine and how it relates. So Dr. Tafuri, since you're the most recent graduate and probably closest to a lot of the people who are tuning in tonight, just want to talk a little bit about what some of the pros and cons have been of doing your residency. And if you could just sort of share your experience with the people tuning in tonight and let them know what you might have wished you had known as a med student.
Sure. So the first thing I wish someone told me is there's a lot of stress when you're going through your clinical rotations to have this like magical aha moment that like, yeah, this is my specialty. And I was really stressed because OBGYN was my last rotation and I hadn't had that moment yet. And I had gone through general surgery and loved surgery, but not liked all of the bowel involvement. I liked anesthesia because I liked being in the OR and being involved with the surgery, but wanted to be on the other side of the curtain doing the surgery. And I had no clue what OBGYNs did. I didn't realize that they even operate. I thought they deliver babies and they work in the office. And I still thought that was great, but there was a whole new world that was open to me when I actually did my rotation. So my first advice is don't write off anything until you're going through it. And everyone has that moment of like, okay, this is for me. This is what I can see myself doing in the future. As far as OBGYN in general, I think I'm obviously biased, but I think it's the best specialty because you get to do everything. Like my passion is robotic and laparoscopic surgery, and I love operating. So I still get to do surgery. And I also like the aspect of primary care and forming that relationship with our patients throughout their lifetime and being there for them in their most like intimate moments and discussing these things that you're privy to, like the most secretive stuff with these patients. And I love that relationship with them and seeing them throughout their life. And, you know, seeing someone for an STD check at 18 and someone else who's 30 with their first pregnancy, and then someone who's 70 and having like postmenopausal issues. Like you see so much in the span of a day. And then of course, going to labor and delivery and helping someone through their labor course and delivery and doing an emergency C-section. It doesn't stop. It's great. As far as residency, every residency you pick will be difficult. There's no way around that. It's time consuming. You have no life. You don't get paid a lot. It's exhausting, but I think you really, no matter where you are, you bond with the people that you're with, like trauma bond basically. And that's great. Like you'll always have this residency family. And I think that, you know, the con of doing residency obviously is just that it's the time, it's the stress. But you know, this is what we're doing. It's, you know, you go to college, you go to med school, residency, for a reason, because this is your passion. So it's important to pick something that you're definitely passionate about because it's a long road. And I think that, you know, I feel like it's definitely worth it. There are definitely hard days that I'm like, wow, I should have tried to be a travel journalist and review hotels or something. Like you always have those days, but then you'll have these really rewarding cases and patients saying, thank you so much. You made such a difference. I feel so better after so much better after my hysterectomy, or thank you for, I had a patient come in today crying. She was 18 and just had a positive pregnancy test and came in bleeding, and she like rushed into the clinic, and I went into the bathroom with her and she peed and showed me the toilet paper. And like, we were in this bathroom. I'm like, what other doctor would be doing this? And what other specialty? Like, this is so specific to OBGYN that we're here. And I'm like in it with her pants down and comforting her. And you just have such a special bond with your patients that is really specific to this specialty. So I love it. And I think that the clinical rotations are really the best time to get that experience. So don't stress that you don't know what you want to do going into med school, because I wrote off OBGYN and I was like, I'll never do that. And here I am. So
Perfect. Thank you. And then Dr. Bernstein, what would you say to current students who are considering different specialties? Why should they consider going to OB-GYN?
So I actually have to say I had a very similar experience. I wanted to be a trauma surgeon. I always knew I wanted to do surgery. I always loved it. I did every general surgery case I could get my hands on during my medical school rotations. And I remember I put OBGYN as my last core because I was like, I don't want to do that. And then I did it. And it was literally 2 weeks before, like, we had to submit our match applications. And I was like, oh my God, I remember crying to my attending, I want to be an OB, but I don't have letters. I don't have anything. And he was like, it's going to be okay. Just relax, stop crying and relax and get it done. But no, I mean, everything Laura said, we see such a wide breadth of different things in one day. And I mean, to add to the residency part of things, I think it's really important to go to a program where you're not going to be comfortable, where you're going to be uncomfortable. You're going to see a lot. You're going to do a lot. You're going to be stressed, because I guarantee you your most stressful day as a resident is your easiest day as an attending, when there's no one behind you checking you, when you see something weird and you don't know what it is. You draw on those experiences you have during your training, whether it's medical school, whether it's residency. It's essential. And so I'm so grateful for the training that I had at St. Peter's Hospital in New Jersey, just because I saw so many different things and so many different presentations, and I got to experience so many different managements of similar conditions to kind of see what I like and what I don't like. And that I'm just so grateful, like I said, for my medical education as well as my residency training. I think it's important to keep your mind open. I also think it's really important that there's something to learn from every rotation. So I have medical students occasionally rotate through my office, and I had a medical student who was interested in GI, and obviously OBGYN and GI, not really, there's not that much overlap. Dr. Osborne's like, but I had a patient who had cholestasis of pregnancy, which is when your liver isn't working as well as it should in pregnancy, and it can actually kill the baby if the levels get high enough of the bile acids. And he was like, oh my God, I had no idea there was like real medicine involved in OB. And I'm like, we're not just like catching babies in fields here anymore. Like, and especially unfortunately, as our American population becomes more and more unhealthy as far as chronic diseases, hypertension, diabetes, we're everything. I mean, I've had to hold patients in my office for hours until I could get an ambulance to take them to the psychiatry unit because they were worried about hurting themselves. I've had patients, bleeding in the office where you're holding pressure on something and getting them over to the hospital. You never know what you're going to get, but it is a very wide variety of things. And that's why it's important that no matter what you want to go into, every rotation in medical school is a gift. And it's a learning experience, and you need to keep your eyes as open as you can and keep your mind as open as you can, because that to me is essential to becoming a well-rounded doctor, no matter what you go into.
That's great. Thank you for sharing that. And Dr. Osborne, you have a little bit of a different perspective as a surgeon. So was just wondering if you could share with everyone tuning in tonight what advice you have for current and prospective surgeons.
Okay, thank you. Dr. Bernstein kept speaking about the influence and the trust that the patients put on the give to the doctor, where they feel that they are able to confide in the doctor. But with such great trust comes great responsibility. And what I would like to say to the students, the medical students, the prospective OBGYN, general surgeon, I hope many of them, is that persons are going to be putting their lives literally in your hand. And every time you feel like taking a shortcut, going back to bed, not studying an extra hour, you've got to think at the end of this section that you're learning or reading or practicing anything, that life is going to be on the other end, depending on you to make the right decision. Because sometimes in this career that we have chosen, medicine, because it's a really tough one, patients' life are literally in our hands. And if we don't put in the work now, where we do the extra reading, where we do the extra revision, we ask the necessary questions, we clear up any doubts, somebody's life is going to be affected down the line. And we've got to realize that this is a reality that we all face. A diagnosis is going to be missed if we don't know exactly what we're looking for. We don't take the time to examine the patient completely, thoroughly. You're going to miss something that should have been seen and addressed immediately, and it then comes back to cause the patient to lose their lives. That some persons, like Dr. Tafuri spoke of her aunt who passed away, who had a lump and went and was seen by the doctor and was told that it was nothing. So it's very important. So for those who are listening out there at this point, if you're really interested in this field of medicine, it takes a lot of sacrifice. If I could live my life over, I would probably do accounting. It would be easier. But, this is something that we love, because medicine is really a calling, and I'm very passionate about what I do. But I really think that we've got the students at this point, and many of us who are in the field, we still have to continually learn, continue to revise, continue to ask the necessary questions, do the research, because persons are depending on us, not only our families, but those in our communities, those who are going to walk into our office, maybe not today, 10 years from now. Our preparation that we do know is going to be extremely important. So that's what I would encourage the young doctors to keep in mind.
So Dr. Osborne, I'm sure that all of your patients and your family and your community are very happy that you did not become an accountant and that you stuck with it and went into general surgery. I'm sure they're very happy that that was the path that you took. So thank you. And I would say the same for Dr. Bernstein and Dr. Tafuri. Just listening to you tonight, it's very clear that you are very dedicated to your patients, and that you have just a lot of compassion for your patients, and that you provide the highest level of care. So I just want to thank all of you for joining us tonight. Just want to give the audience one more opportunity. If you have any other questions, to drop into the chat, we'd be happy to. We're a little bit over time, I realize, but if there are any other questions, we'd be happy to address those now before we wrap up for the night. And also before the call, I did confirm with Dr. Bernstein and Dr. Tafuri and Dr. Osborne that if you do have any follow-up questions, that they'd be available to respond to you. You can reach them through LinkedIn. I'm trying to see if there's a way that we could also share their email addresses if you wanted to reach them via email. Maybe Dr. Bernstein, Tafuri, and Osborne, if you could drop your email into our chat, maybe there's a way that that our host can share those with the audience. But again, I just wanted to thank everyone for tuning in tonight. It looks like we're trying to share email addresses now. So hopefully we can do that. Perfect. I see one for Dr. Tafuri and one for Dr. Bernstein. Thank you. But once again, we really appreciate Dr. Bernstein, Dr. Tafuri, Dr. Osborne taking time. We know that you're very busy and your personal time is precious. So we really appreciate you coming on tonight, sharing your expertise, sharing your experience, telling stories that make it very personal and just helping to raise awareness. So thank you so much for tuning in tonight. And with that said, we're going to be wrapping up tonight's live stream. It is being recorded and will be posted to the UMHS YouTube. So if you'd like to come back and rewatch or share, please do. And that should do it for us for tonight.